Yep. All righty. Well, welcome everybody to VerAvanti's Future on Intravascular Imaging. I'll play this here.
At VerAvanti, we're on a mission to redefine intravascular care.
At VerAvanti, we're on a mission to redefine intravascular care. Millions are affected by heart disease and stroke every year. Yet existing imaging technologies often leave clinicians without the detailed visuals needed to address complex challenges. These gaps can make procedures more difficult and less efficient. That's why we're developing the scanning fiber endoscope, or SAFE, a next-generation imaging solution designed to provide high-resolution, real-time visuals inside arteries. SAFE is built to deliver sharper, clearer imaging to help interventionalists navigate complex cases with more precision and confidence. We believe that with this new technology, clinicians may be able to identify issues earlier, treat patients with greater precision, and reduce the need for repeat procedures. With a single-use design to reduce contamination risks and compact fiber optic technology for minimally invasive procedures, SAFE is designed to enhance procedural efficiency, simplify workflows, and improve the overall experience for clinicians and patients. At VerAvanti, we believe better tools pave the way for better care. If you're interested in exploring the unique capabilities or partnership opportunities, reach out today by contacting us at veravanti.com.
Hey, Luis, welcome to the show.
Thank you. Thank you for the invitation.
So you're probably going to have about a mix of finance people, salespeople, and a lot of doctors in front of us. So I'll leave it up to you to take us through the slide deck, and then we have a Q&A at the end of the session. And if people want to post questions, feel free to put them on the chat, and I'll be able to address them as we go along. And if I don't have the answer, I'll interrupt Luis, and he'll respond to the questions. Okay, Luis.
Thank you, Juan, for the introduction. Happy to be here. So very briefly, I'm a vascular neurosurgeon, MD, PhD by training, and within my clinical practice, I am half my clinical work is open and half is endovascular in San Francisco. What I was planning to show today is the work that we have been doing with this new intravascular imaging tool within the cardiovascular field. And there are a few comments that I want to do before basically starting the presentation. First of all, that the technology currently is not approved or cleared by the FDA. So basically what I'm going to show is not about a specific indication to use this technology for a patient. Has more to do with the use of these new tools to see better, to understand better what is happening inside the vasculature, and how we can use this new vision to drive our diagnosis, our capacity to prognosticate what would happen with a particular lesion, and as well to decide how we could potentially treat a certain lesion the best, both mechanically with devices or pharmacologically. As I mentioned, I am an endovascular neurosurgeon. So most of my focus is basically from the clavicles up, carotid disease and intracranial. But I'm mostly going to be talking about atherosclerosis. And I'm going to be presenting some examples as well affecting the coronaries and the peripheral vasculature. So there is a lot of overlap for the audience that is interventional cardiologists, vascular surgeons, and interventional radiologists. So I was thinking how to start the presentation, and I thought about starting by the beginning, which is this. What you're seeing here is the first documented X-ray in the medical field, which is basically a hand from Röntgen's wife That was actually 1895. And using X-rays, just within 20, 30 years, there was the origin of our endovascular field, which was the injection of radiopaque contrast inside the arteries, specifically inside the carotid, try to understand what was happening inside the brain or trying to diagnose strokes. And this was one of the very first publication in 1937, almost 100 years ago, showing the occlusion of the carotid artery on a patient having a stroke. And I think just by looking forward what has happened in the next 90 years, it's pretty amazing how we were able to use the shadows casted by X-rays upon contrast to understand what was happening in the vasculature, and basically to do currently more than 8 million procedures per year. And you can see that what these procedures they have all in common, regardless in what part of the body they are done, is that we are placing catheters inside the vasculature, injecting contrast, and when the contrast flows downstream, we can see narrowings or we can see blockages of different types. And that's how basically we still do the procedures currently. In the last, I would say, half a century, there has been a feeling that X-rays was insufficient to really understand what was happening inside the vasculature. And that has led to the development of advanced imaging tools to navigate inside the artery and take images from the inside, what we call intravascular imaging. And this is just a video downloaded from YouTube that shows basically this concept, which is there is a narrowing here identified by angiogram, then a wire is crossed on the lesion, and then over the wire we are advancing an imaging tool, and the imaging tool is able to scan sideways, to look sideways. So we just go back and forth multiple times, and that is able to create pictures that we try to interpret. And that are basically the intravascular tools that we have in our clinic and that we're using. And there are two major types of technologies. One is intravascular ultrasound, as you can see here on the right. The other one is optical coherence tomography, or OCT. And these are the kind of pictures that are generated. This helps, and in some vascular territories, about 20-25% of procedures are being done using these tools. But there are some shortcomings. First of all, is that typically we don't see the world around us on acoustic shadows that provided by ultrasound. And we don't typically see this light scattering, which is provided by OCT. So that by default makes interpretation of the images really challenging. And often these images are very subject to artifacts. In this case, for example, you cannot tell if this in the screen at the top or at the bottom is something real, is a real structural lesion in the vessel, or is just an artifact caused by, for example, blood flow or pulsation of the blood. So that brings the point that interpretation of the images is actually very challenging on real life. The other thing that is important is that if you think about how we do procedures, and I'm not talking about how we measure things, how we measure narrowing, how we can measure the stent sizes. I'm talking about doing procedures, basically moving wires, catheters, stents, deployment. We're still relying on X-rays. We don't have any intravascular imaging tool that is actually able to see forward on real time to be able to guide our procedures in a way with an endoscopic view. Having a camera inside the vessels that is looking in front of your tools and can tell you where you need to go, what you need to do. In a way, it's like driving inside a tunnel. If the tunnel is the artery and you're driving, it's really hard to drive if you can only look sideways and you need to go into reverse. What you need to is something that is shining a light in front of you and you are able to see in front of you while you are driving and doing things. So that is something that you would think that an endoscope would be able to solve. And if you look basically head to toe, we do have great endoscopic advances in the ENT space, gastroenterology, urology, pulmonology to see the lungs, etc. But we haven't had that within the cardiovascular field, at least not that has been widely adopted. And if you really look at the endovascular endoscopes, this is not a new concept, actually. The first endovascular endoscopes or angioscopes were introduced back in the 1980s. And in some countries, they're still being used, like Japan. And then, no, this is just an example of a Japanese society dedicated on angioscopy. And these are the images that are generated by those angioscopes. The problem here that you can see how the resolution of these images is extremely low. It's really hard to interpret what is happening here based on the resolution. And the main problem is that these angioscopes, they work well when they are very large, like a centimeter in size, because those are kind of the devices used to see the esophagus or the colon, for example, like very big cavities that would allow you to put very large endoscopes. Once you go to the millimeter or smaller, you're very limited in the amount of fibers that you can use to generate images, because these endoscopic technologies are based in something called coherent optical fibers, which this is the idea. You have multiple fibers that you bundle together, and what you are capturing on one side at the tip of the camera is coming out from the other. So basically, this has led to devices that are too big to be placed inside the vessels, or they are small enough, but they are not providing enough resolution. They're very low resolution, and the image quality is not enough to justify their use. So what VerAvanti has done, which I think is very exciting, is developing a completely new optical technology, which is taking one single optical fiber and using that single fiber to make the work of 1 million fibers together. Okay, and this is basically the core technology, which is called scanning fiber endoscopy. What you are seeing here is a single optical fiber that travels along a small catheter or microcatheter to the tip of the catheter. And within the tip of the catheter, there is a MEMS actuator, this microelectronic machine that is actually a scanner. And what the scanner is able to do is shine the laser beam following a spiral path, basically multiple concentrical rings from the center of the visual field all the way to the periphery. And that is the way images are generated just by scanning one single optical fiber. Another way to see this, it's with this representation here. What you can see in the animation is the similar concept, which is a very thin microcatheter, a millimeter or smaller, that has this single fiber, which is scanning at extremely high speeds. And the scanning is done following this spiral. And that spiral shines the light throughout the visual field 30 times each second. That creates 30 frames, 30 images per second that then they are generated into videos. So when you are basically seeing with this, you are seeing practically on real time a video from the inside of the vasculature. The other thing that I want you to notice is that that dot over there represents the laser beam. And as you know, you can overlap multiple lasers at different wavelengths to travel together. So in this case, if you look at this magnified, you have the blue, the green, and the red colors, which are three different lasers that are being scanned. And those three colors are the colors that our retina, our eye and brain can process. So this is actually equivalent to putting your eyes inside the vasculature. You are generating true color images. The other thing is like the laser itself is very small. You can see that the mode field diameter, which is kind of the diameter of the beam, is smaller than a micron, which translates into a pixel size smaller than a micron, or if you look at the screen, over 1 million pixels. So, in a way, this is probably the highest definition endoscopic technology at this size that has been built today. And that is something that is enabling intravascular imaging at very high resolution. And this is an example of the angioscopic images that you can generate with this. Again, this technology, the catheter itself, is 3.3 French, or about 1 millimeter. It's compatible with a monorail system, or basically has a monorail system for rapid exchange, so it allows you to operate over a wire. The images are forward view in true color, and you can see that the whole visual field is illuminated and in focus. So what we have done for the last few years is to understand what this technology could enable us to see. We started by doing a pretty comprehensive preclinical analysis of a few hundred surgical specimens. In details, we use carotid and arterectomies because those are most of the time complicated atheromas, meaning that there is unique architecture in the tissue that we could analyze with this technology. And then we use as well autopsy specimens, mostly in coronary, basically heart attacks, deaths, and the human cadavers. And then we started developing the procedure to use this technology in large animals. Okay, and this is just a quick view of how this looks. There are two components here on the right. It's basically the console where there is the computer, there is the laser power, and then we connect the imaging catheter, which is single use and disposable, to this machine. And that is the part of the system that goes inside basically the patient in the future. And this is how it looks. This is the tip of the device. This is a side view, which, as I mentioned, is about 1 millimeter in diameter, and the tip itself is about 5 millimeters. So what I'm going to show you in the next few slides is how normal vasculature looks like, which is the same video that I was showing you before. And then I'm going to walk you through cases where the vessels that were diseased, both asymptomatic and symptomatic. And then we can discuss basically the potential implications. How would this potentially help us clinically? So what I was showing you here is the case of a normal artery. You can see that the surface is very smooth. There are no fractures. There is no calcification. Those are the branches of the vessel coming out. Different to this case, which is a diseased artery that has multiple types of calcification. You can see that there is a calcified plaque, and there is even a nodule over there. Okay. So one of the things that we can see is if we can really characterize the plaque that is causing a narrowing, we could potentially tell what is the likelihood for that particular patient to have a new cardiovascular event from that specific lesion. And imagine that you have this situation. You have this elderly lady, 88 years old, that had recently a major GI bleeding that comes to the hospital because she woke up at 2 a.m. and she was having difficulties to talk. Unclear if this is a aphasia or dysarthria or she was just confused. This is a CTA. You can see that there is a heavily calcified plaque, eccentric, in the proximal internal carotid, causing about 80% stenosis. So the question here is what to do with this lady. Should we do endarterectomy or stenting? Should we give her antiplatelets despite the recent GI hemorrhage? Or maybe she just is an old lady that woke up at 2 a.m. and she was confused for a few minutes. And this is just a very innocent bystander. So imagine that, and it's really hard to tell just based on the CTA. But what if you can get this type of intravascular images? You can see here, this is the external carotid, this is the internal, and you can see that there is a calcified atheroma, which is causing 80% stenosis. But you can see that this atheroma is not disrupted. There is no fracture, there is no thrombus. It's probably just an incidental finding compared to this other atheroma. That, again, C-shaped calcified atheroma causing narrowing, but you can see that there is a clot sitting in the surface of the vessel. And if you can see the clot, you can likely identify that this patient actually is at high risk of a recurrent stroke. So that would justify the risks of antiplatelet medication and even an intervention. So be able to really distinguish these easily incidental finding versus a rupture atheroma to drive basically potentially your decision about the next steps. One of the things that we don't talk often is the chronicity of the lesion. By that, I mean that, yes, sometimes we can detect narrowing or stenosis, or sometimes we can see ulcerations or dissections, but we don't typically talk about how old is the lesion. Is this something that, is this ulcer a couple of hours old and is likely to cause another stroke or a heart attack? Or maybe this is an ulcer that happened many months or years ago and is healed already. And let me show you one of these examples. Imagine that you have this 62 years old male that has a TIA, basically difficulties moving the hand for about 10 minutes. Pretty convincing that this was a TIA. And then you do the workup and it turns out that there is an ulcerated plaque. You can see over there in the carotid, ulcerated plaque with 50% stenosis. But in addition, the patient is having these short episodes of AFib on telemetry. So the question is, what do you treat? You treat both things or maybe one and not the other? It's really hard to tell. And one of the problems is like we can see the narrowing, we can see that there is an ulceration, but we don't know if this is acute or chronic. And imagine that now you can see this. What you are seeing here is basically the surface of the artery, and those two are fresh or acute ulcers. Okay, you can even see that on the ulcer on the left, the tissue is very friable. That's the necrotic core, and that is something that is being washed to the brain every single heartbeat. So definitely, if we see this, we can assume that this is the root cause of the TIA compared to this other case. So what you are seeing here is the bifurcation of the vessel. This is the external carotid. This is the internal carotid. But if you really pay attention to the right side, you can see that there is, coming from the internal side, there is a big ulcer. There is a big crater. But this is a healed excavation. There is thick fibrous tissue. which I'm going to show you again. You can see that there is maybe a tiny clot, but not much. So in a way, this is a chronic healed ulcer that we should not probably be treating. Maybe we have to pay more attention to the AFib for this particular patient. Okay, so these are things that we can start seeing if we have this kind of image quality intravascularly. Another problem that we're having is that when we see these narrowing or these occlusions, we cannot really tell what is the tissue that is causing the blockage. We have several options in the shelf about removing clots, using balloons or stents, or doing lithotripsy. But the challenge right now is to really identify what is the best tool or combination of tools to reopen that particular artery, especially when the artery is completely blocked and we cannot cross it with our side viewing devices. And by that, I mean that there are situations, as you all know, especially in the coronaries, that a STEMI can have high or low thrombus burden. And these are some papers using the meta classification that tells you, okay, just based on the appearance of the contrast, there could be more or less thrombus. We're not talking about basically anything specific here. We cannot tell that if the thrombus is acute or chronic, or if it is actually thrombus or something else, but that's what we're using right now. So, and if there is high thrombus burden, we should probably consider doing thrombectomy to clean, to aspirate as much thrombus as we can. These are some examples that you could potentially distinguish and characterize if you have this type of intravascular tool, this laser angioscopy. What you can see here is an acute thrombus. This is a carotid endarterectomy specimen that was resected within 24 hours from the stroke. So we know that the patient had a stroke within 24 hours. We're removing the tissue. So we're pretty confident that this is a fresh clot. You can see that it's red, it's not organized, and is basically almost occluding the whole lumen except that tiny residual narrowing. Here you have and by the way, if you have a fresh thrombus, just based on clinical experience, suction thrombectomy works really well. And then thrombolytics medications to dissolve the clot works really well. This is a different scenario where this patient had a stroke 10 days ago. So during these 10 days, the thrombus has been slowly undergoing organization. It's getting stable. And you can see that there is the arteries here. You can see the thrombus, but you can see how there is this layer of fibrin and basically white tissue that is slowly organizing the thrombus. This is a thrombus that it's less likely to be removed by suction thrombectomy. This is potentially a good case to use a stent to reopen the vessel, to push the thrombus away. And then this is another case. This is a case actually for my practice, that this is a patient that presented with a critical stenosis of the carotid. You can see that there is a tiny amount of flow left. In this case, there is as well a thrombus, but the thrombus is not within the lumen of the vessel. This is what we would call an intraplaque hemorrhage. You can see that there is some red here, which is related to a hemorrhage, to a thrombus, but that thrombus is inside the plaque. And that's important because within the lumen, there is nothing to really aspirate with the suction catheter. If we give medication to dissolve the clot, the medication, they're not going to be able to reach deep into the plaque to dissolve the clot. It's a different strategy. We need to reopen the vessel by using a balloon and a stent. But the problem is, like, if you look at the top, there is a very big ulceration. And as you can imagine, it's going to be easy to push the wires through this ulceration and make the problem worse by disrupting this soft plaque. What we need to is to find that tiny hole that leads to a channel that would allow us to cross this lesion. And with x-rays, using shadows, that can be challenging. But if we have a direct endoscopic view, then you know exactly where to advance your wire to find the hole and then cross the lesion. So these are things that are being enabled by this laser angioscopy. And then Juan, please let me know if you have any questions along the way in the chat, okay?
Sure.
Thank you. So another thing that is important is when we talk about calcium. As you know, calcium, it's linked to a risk of cardiovascular events, but there are some conflicting literature showing that actually calcium is related to stable lesions. And the problem is, like, not all the calcium is the same. It's unfair and not precise to just quantify the amount of calcium and try to answer this paradox. There are several papers, actually, great work, trying to use IVUS and OCT, trying to provide strategies to manage the calcium. But the problem is that it's really hard to distinguish the type of calcium. How do you know the type of nodule that this bump represents? Is that a nodule which is benign, that is never going to cause an issue and is just an innocent bystander? Or is something that is actually causing heart attacks or strokes? When you start looking at this with laser angioscopy, you can start identify very distinct phenotypes of calcified lesions. This, for example, is simply a calcified sheath, which is this dystrophic tissue, mostly collagen, that has calcified. Different to this nodular calcification, you can see this micro CT, that you can see a true nodule of calcium, which is partially within the lumen, partially within the vessel wall, which corresponds to this, okay? But if you look at this nodule, you can see that looks pretty benign. There is smooth tissue covering the nodule. There is no clot. There is no evidence of an active process that could result in a heart attack, compared to this nodule. That is what we would call an eruptive or eruptive nodule. You can see that the phenotype here is very different. You can see how there is this irregular nodule that looks almost like a coral, which is mixed with thrombus. And we know by pathology, by doing autopsies, that these type of nodules are malignant compared to the benign nodule that I was showing you here. Okay? One of the things that we don't talk as well, that sometimes the nodules can actually move, they can be mobile. And again, you're not going to be seeing this by OCT or IVUS. You need this type of angioscopic views on real time to be able to detect that nodule, which has actually barely anchored by this fibrin connection to the surface of the vessel. And then there are situations where the calcification is absolutely exuberant and creates these chronic total occlusions, which we all know that these are really challenging cases where we have a combination of plaque and thrombus which has been calcified, and then we need to cross. And then if we have these views, we can find where are potential channels to push our wires to cross these chronic total occlusions. So what I have been showing you so far are examples of lesions causing narrowing or blockages. But as we all know, there are lesions that can cause symptoms without narrowing the arteries. Okay, that is something that within the neurovascular space we call SNC, symptomatic non-stenotic carotids or plaques. And these are actually clinical examples. Patient having multiple strokes on the right side, the patient never had a stroke on the left. So it was very likely that the culprit vessel was the carotid artery on the right side. This is the CT, and the CT actually, you can see that there is a calcified plaque, but it's not that impressive. So what we decided eventually was to do an endarterectomy on this patient because he had half a dozen strokes within a few months, despite maximal medical therapy. And then what you can see in the specimen is this. What you have here is the bifurcation of the carotid. This is external, this is the internal. And then you can see that on the internal carotid, the one that goes to the brain, you have multiple fresh clots over there and over there that were basically in a ruptured plaque that was not causing much stenosis. There was some calcium, as you can see here and in the CT, but not significant stenosis. And that was a patient that had cryptogenic strokes, which means strokes of unknown etiology or root cause that could have been diagnosed if we have a tool to look intravascularly with high resolution. The other thing that is even more equivocal to see is something that we call erosions, which is when the endothelial layers, basically the lining of the vessel, is detached, and that allows thin clots to form. And then what I want you to notice is this red staining, okay? That red staining actually are true erosions. If you look that with a scanning electron microscopy, this is what you're going to see. You see red blood cells in very thin layers, which are being deposited and trapped by this fibrin network. So this is, in a way, the first tool that can actually show you erosions. And the paper showing this was actually just accepted for publication in JACC. So it's going to show up in the next few weeks, I hope. The other condition that can be challenging to identify, but is critical because it causes basically sudden death from heart attacks without significant narrowing, is called plaque fissures. So plaque fissure is the situation when you have a lumen which is open, but you have a fracture on the surface, and the fracture extends to the deeper layers, and then is typically associated with a plaque hemorrhage. And then if you look at this, you can see that in the lumen, there is a very thin, subtle fracture, which is what you are seeing here. What you are seeing here is the artery, which is completely open, but you can see that there is a longitudinal fracture, which is actually a fissure that in this particular case caused a sudden death. So this is one of the autopsy specimens that I was explaining before. The other thing that it's hard to see and is important to identify in the surface of the vessel is this. This is the degree of endothelialization of a stent, okay? Imagine the situation that you have this gentleman that had a carotid stenting a couple of months ago after having a stroke, and then he's on antiplatelet medication. And due to the antiplatelets, he presents with a massive bleeding from the colon, like a massive GI bleeding. So the question is, what should we do? Should we stop the aspirin? Should we give platelets? Is safe to do so or not? And the answer to that, it's likely about what is the degree of endothelialization of the stent. So what you are seeing here is the vessel. And that's the bifurcation of the carotid. And then you see that there is no stent, which is fully covered by intima, until you keep advancing, and then you see some of the tines of the stent. But in this case, the stent is mostly covered. There is no thrombus. This could be a potentially reasonable case to stop the aspirin with low risk of thromboembolism from the stent. So that,
Luis,
yeah.
we have a question for you. It's relating of being able to see through blood.
Yeah.
Do the lasers pass through blood, the dark fluids? Can you explain how we do it today and what the plans are?
Yeah, great question. So right now, what we're doing is doing something similar to OCT, which is injecting saline or injecting contrast, and that allows us to have basically a segment of the vessel without blood. And I'm going to show you some examples of that in large animals, and then I'm going to show you the next generation that we are building. So what I'm going to show you here are some of the examples of in vivo angioscopy. I'm going to start by showing the placement of the camera within the aorta of the rabbit, in this case, without flushing, saline without injecting contrast. So this is the view that you will get, okay? At this point, you can inject saline or contrast, and when you're doing that, you generate these kind of images. You can see at the top here that there is still some blood flowing. You can adjust the amount of fluid or the inflation of a balloon, if you have one, to obtain this kind of views. And then if you're using a balloon guide catheter, this is the kind of images that you can generate. You can see that occasionally there is some small amount of blood flowing back, but that is something that can be corrected by different infusion rates. What I was showing you is a completely healthy rabbit. This is an animal that has been fed with high cholesterol diet for several months. You can see how the vessel has developed these extensive atheromas, but there are still intact atheromas. They are basically not complicated. And what you can do in vivo is intentionally disrupt these atheromas. And this is the kind of images that you generate in vivo. Here you can see a clot, for example, that is extending. You can see a dissection flap over there. And these are all disrupted atheromas. Those that was showing you are atheromas. This that I'm showing you is actually a more advanced disrupted atheroma with infraluminal thrombosis. What you can see here is the clot that is extending for long distances. You can see that the clot is anchored or attached to the endovascular surface by this fibrin network, which that is what would define an in situ formation of the clot, which is different than this situation. This is an embolus, is a clot that was formed somewhere else in the heart, for example, and then the clot has embolized. So it's truly an embolus that you can see that is completely occluding. And if you look at the clot, it was kind of white and platelet rich, which is very different to this red embolus. And then finally, the other type of occlusion that you can have is a dissection. In this case, you can see that there is a dissection here. That's the false lumen. And then what you can see on the left side is the true lumen. So by knowing where to go, you can select the true lumen and you can cross these dissection flaps. And then, of course, you can decide how to reconstruct this or stent if needed. So those are some of the images that generated in vivo in rabbits. This is a similar model in swine, though, like even larger vessels. In this case, there is the artery. You can see that there is a side branch, and under direct visualization, we can navigate our tools. And these are some extra videos from one of our collaborators, Dr. McVeigh, from the University of Toronto, that in this particular case, he's using a stent retriever to recapture a clot entangled into a stent. Basically, he's doing a thrombectomy over there. And then you can see that there is some blood, which is refluxing. In this case, it's a renal artery, but he's still able to obtain a very good intravascular view. And finally, in this other video, Dr. McVeigh, he's deploying coils as well under direct visualization. And these videos have been published previously in a journal called Neurosurgery with Patrick as first author. So if people is interested, they can find it over there. And so that is currently how we're using the technology, how we're flushing the blood, and how we're doing procedures in these preclinical models. In addition, what the team at VerAvanti's is doing is working in platforms that could potentially enable visualization through blood. And by that, I mean this work that is as well courtesy from Dr. McVeigh, which is using specific lasers in the near infrared spectrum that can travel through blood, and then coupling that with highly sensitive receptors, which are able to construct these images. And in this case, Patrick had inserted coils in this renal artery, and then he's actually navigating back inside the artery, and seeing through blood, he's able to identify the coils and the clots that are being generated on top. You can see that we have compromised the true color to generate these images, but these images, they can still show you like metallic implants, for example, like this is a platinum iridium from the coils, and this is a clot. So potentially seen through blood could be a breakthrough, not just in the arteries and veins, but as well for structural heart disease. Again, this is still exploratory, is under development, but we hope that basically as physicians, we can use this in the next few years as well. I'm not sure if that answered the question, Juan, that somebody was asking.
Yeah, it was Dr. Rias. I'm waiting to see if he responds to your answer, but I think it's clear to know that this is the early stage research project that we have engaged with Patrick to come up with a higher quality resolution, I guess, for the next version. But yeah, this is our first stand at seeing through blood, and there's more to come.
Yep. So just like moving along to the concept is everything that I showed you so far has been using this full color platform, or the blue, green, and red. As I mentioned, you can scan different lasers, and one of the options is to use this near infrared laser to see through blood. But similar lasers in the near infrared window, they're being scanned to generate OCT images. So another of the basically platforms which is in the R&D pipeline is the combination of a full color angioscope with OCT. And what you can see here, for example, is the endoscopic view of, in this case, a finger. And then imagine that you can draw a line using a software in this computer, in this console. And that line is going to instruct the machine to use this near infrared laser to generate OCT images in depth, basically for the first few millimeters of the tissue. And that is going to be displayed next to the endoscopic view, basically on side by side, so you can see the first few millimeters. In this case, that's the epidermis, and that's the dermis underneath. So, still more work to be done, but definitely this has a lot of potential to characterize the plaques better, and potentially to find channels when we are dealing with chronic total occlusions. Like in this case, for example, you could potentially navigate to the occlusion, and then you could inspect the chronic total occlusion, and then you can say, okay, I think that hole could be potentially be a channel. So you would place that yellow line to bisect that hole, and then you're going to see in depth how deep that hole goes for the first few millimeters. And then one of the other things that we're exploring as well, it's the potential of using laser angioscopy to do molecular imaging, to understand the biology of the plaques. This is relatively old now. This is from 2008. Now we know much more, but this is just to exemplify that in the last 20, 30 years, our understanding of the biology driving the fate of a plaque has dramatically improved. And now we know which are the main molecular pathways driving inflammation or angiogenesis, for example. And if we can target those pathways, we will be able to do biological imaging in addition to the structural imaging. And the idea here is the following. Imagine that you have a plaque, and the plaque has these inflammatory cells, or they have, for example, enzymes which are digesting the tissue, like MMPs or metalloproteinases. What you could potentially do is to give molecular probes which are fluorescents, and then you can use this laser scanner to look at the molecular probes. And this is an example of what is happening in the surface of a vulnerable plaque. What you are seeing here is blue from the collagen, and then everything that you see in red is fluorescence in red generated by MMPs or enzymes that are digesting this collagen. Okay, you can generate these images using very, very large multiphoton microscopes, which are large as a room. But what if you could take exactly the same principles and do similar images in vivo inside patients? And this is that proof of concept. This is a patient that comes to the hospital. Unfortunately, he had a coronary stenting, but the patient dies for cardiogenic shock. And then we looked at the vessel, and then we used the same red substance to look at MMPs or inflammation. And you can see that this particular patient had a massive amount of inflammation in that vessel. You can even see the tines of the stent that cause even more inflammation. And maybe that is a patient that would have benefited from a high concentration drug delivery using drug-coated balloons. At this point, we just have a couple of options using paclitaxel and sirolimus, but the more specific we can be with our imaging approaches to understand the biology of a plaque, the more targeted we can be with our drugs. So in a way, we are kind of on the edge of a big revolution on basically biological modification of plaques. And we put this together in a paper that was published in Nature Biomedical Engineering a few years ago. So I invited the audience to take a look if they're interested. So I think I will leave it here, Juan, for now, and I think we can open for questions and answer if there is any outstanding.
There's nothing on the queue right now. So it was excellent presentation. Thanks, Luis, for doing so. Maybe I'd like to introduce Gerald, who is the founder of the company, to explain a bit of the company background and what our plans are for what's coming down the pipeline. Gerald, you're muted. Sorry. Gerald, you're muted.
Hello, everybody. Gerald McMorrow here. Thank you for watching this excellent presentation from Luis. We're planning on getting these products to market in 2026. so you can begin to see the RGB SFE in action, and followed on by more products to give more definitive imaging capability.
Okay. There are no more questions, Luis. I guess you've done an amazing job. So no.
Yeah.
Yeah. So just my comment as a physician is that at the end of the day, we understand what we can see, and we can diagnose and treat what we understand. And I think that is basically one of the main drivers that, at least personally, and other physicians in the community, that's the reason we're so excited by being able to see better and understand better what's happening with the patients, and basically understand if there are better ways to treat the different conditions that at this point sometimes we're struggling to distinguish. So definitely if the team or no there's people in the audience that is interested to reach out, definitely looking forward to collaborate and to work to put together a task force that is interested to serve our patients better and to do science using this technology. So
Yeah, we'd like to be your intravascular eyes.
Luis, one question that always comes up in meetings like this is, normally as a physician, you're working on a specific problem. How much radiation do you take over hours of work and trying to poke into finding the little hole that the SFE can actually minimize going forward?
Yeah, it depends on the procedure. The more complex and complicated the procedure, the longer it takes. And unfortunately, imagine that a procedure has 10 different steps. Most of the time, there is 1 or 2 steps in the middle, which takes most of the time, complexity, and radiation. For example, when we are dealing with chronic total occlusions, it's easy to identify where is the blockage. You just inject contrast and then you see where the contrast flows and stops. But after that, we need to find a way to cross that blockage. And right now, we are just using kind of the feeling of our fingers when we're pushing the wire and the shadows of the X-rays. If we have a way to know that we're pushing in the center of the vessel, or if for intentionally want to dissect, which is creating kind of a false path through the vessel wall, advance, and then know when and how to regain access to the true lumen, passing the narrowing, that is going to be transformational. That is going to cut 1, 2, 3 hours of those particular procedures. Potentially, you could do it within a few seconds even. So I think each procedure is different, but I think being able to see is actually to see and guide the procedures, and the direct visualization is going to be transformational.
So as you know, I'm not a doctor, but if I hear you right, if I have a total occlusion, I'm basically poking blind, looking for the hole that I can pass my catheter through. And that process can be more dangerous, correct? If I poke in the wrong place?
Yes. That is a fair statement. Ideally, you want to be able to know exactly where you are advancing and pushing. And if for any reason you have dissected the vessel, you need to be able to find your way back into the artery, into the lumen. And sometimes you want to do that intentionally. But in a way, the capacity to do this through recanalization is very challenging, actually. I think it's interesting because we always think about the imaging tools, but at least what I expect in the next 10, 20 years is that once you can see it this way, there's going to be a new wave of devices built around direct visualization. Meaning that now that you can see, you're going to develop new tools that can be operated with direct visualization, not X-rays, as we currently are doing. So I think we are in exciting times.
Well, it sounds like let's talk a little bit about the long-term vision, because every person over the age of 50 has to get a colonoscopy done, and those big fiber bundles that you mentioned originally. But nobody ever talks about doing a preventive medicine in looking at arteries in the heart or the brain, like you mentioned several cases. So do you foresee the day where physicians will be not mandated, but requiring some sort of a preventive test using the SFE to take a look at your heart or your brain and do corrective steps before you have a stroke or a heart attack?
Thank you, Juan. And then, yes, let me pull this up. These like the accessory materials, if the people was interested. I think your point was right on. Atherosclerosis is the #1 killer in the Western civilization, definitely in US. When we talk about cancer, for example, we're actually talking about hundreds, thousands of different diseases under a big umbrella called cancer. But when we talk about atherosclerosis, we are talking about a very, basically is a multifocal systemic disease that affects the brain, the carotid, causing strokes, potentially even dementia, affects the heart, causing heart attacks or insufficiency, affects the legs or the extremities. And we don't have great screening tests for that. Basically, if you have, for example, if you are 50 years old or older, it's very common that you're going to have a colonoscopy because there is a relatively small risk that in the single-digit % that you are going to have colon cancer in the future. So if you find early colon cancer or precancerous lesions, you can actually deal with that before it's too late, and you can basically prevent mortality from cancer, like through metastasis. And we're talking about a small percentage, 1 to 3% of people. But if you think about atherosclerosis, maybe 30% of people or more, they're going to have a morbidity or mortality caused by atherosclerosis. And the problem is that this disease is silent until acutely causes a problem. Basically, it advances for many, many years, completely silent, until something changes acutely, typically a rupture of the surface, leading to thrombosis, clot formation. And I think it would be very, very reasonable, and probably the long-term vision of having a subset of patients that are at risk for cardiovascular events. For example, they are smokers, or they have high blood pressure or cholesterol or diabetes or family history, that at a certain age, they undergo a screening test. Ideally, the screening test, they have to be non-invasive. So you can basically deploy these tools at very large number of population, very large number of people. And then that screening tools, they need to be very sensitive to detect patients likely to have these risky plaques or vulnerable plaques. And of those patients, then you basically, rather than doing a colonoscopy, you do an angioscopy. You look at their arteries, coronaries, renals, carotids, looking at the presence of high-risk plaques. And I brought up this slide because, fortunately, there has been great research being done for the last 20, 30 years about what are the plaques that are considered vulnerable or high risk. And actually, one of the pathologists is Dr. Rino Virmani, which is a great pathologist and one of our collaborators from the lab. And this is a paper that was published in JACC very recently, showing these 3 lesions which are vulnerable. One is the plaque rupture, one is the erosion, and finally is the eruptive calcified nodule. And these are three basically OCT images that I extracted from the paper, that it shows you, okay, this is likely an ulcer, or maybe artifact, but maybe is an ulcer. This in theory is clot at the surface of the vessel, and this is an eruptive calcified nodule. And this right now is the gold standard. This is the best that we can do for our patients. And what you are seeing here are images of the same lesions with angioscopy. And I showed some of these lesions before. What you are seeing here are ulcers that you can clearly detect these big craters. These are erosions, as I was showing you before. And these are these eruptive calcified nodules. So what I think is that with these new tools like laser angioscopy coming to the clinic, we're going to be much better to truly identify these type of lesions. Like no more guessing. We're going to be able to see this. And then we're going to have two strategies. And maybe we're going to do one or both. One is going to be what we're currently doing, which is dealing with the systemic problems, the blood pressure, stop smoking, lowering the cholesterol, controlling the diabetes. The other thing that is very likely that we're going to be doing is delivering drugs, medications locally at high concentration to deposit high volume of those drugs into the plaques that are actually vulnerable. In a way, it's like smart drug delivery. You're going to treat the whole body for the diabetes and the blood pressure, and then you're going to give specific medications here to allow the endothelium to heal or the inflammation to be reduced. So I think that is where the cardiovascular field, in a way, is going to go, is this individualized medicine by leveraging these better imaging tools.
Well, that'll be a game changer. So this is one, and the other one would be being able to see through blood. That's another game changer that is in the near future for us. Well, Luis, thanks for the time. Thanks for the audience that was attending today. This presentation will be put on the company website, VerAvanti.com. And if anybody wants a link to it, I'll be happy to send it to you via email. And we hope to do a similar presentation in a couple of months or so as we advance the technology and show you new videos. But for now, again, thanks for the time, and we'll see you very soon. Take care. Thanks, Luis.
Thanks for the invitation. Bye-bye.